other respiratory issues.
Because I think we talked about managing a ventilator first go round, and now we're talking about APRV was the talk. APRV is really a mode for oxygenation failure. Now that we have this epidemic of flu, this proning really working well. And this is the video this is the video by the people that did the big study in New England Journal. So this is linked into a computer in every ICU. Since Arlinger pays for the journal, and she will put it in the system somewhere. So I'm going, and actually our lift team, Bill and others, they know exactly what to do. I mean, they have been, Bill even has a system how to do it. So I can let it just run, or I can just speed it up. It's up to you. It's only a couple of minutes.
To prepare the procedure, at this stage you have to decide which direction to turn the patient, to the left or to the right. Priority is given to whichever side the central venous lines are located. Check the length of the vascular lines and the transcutaneous saturation cable to be sure they are long enough. Move the ventilator as close to the patient as possible. Check the patient's hemodynamic status and the level of sedation. Secure the endotracheal tube and the gastric tube. Protect the skin on the forehead, knees, iliac crests, and thorax from pressure sores using adhesive pads. Protect the patient's eyes and get the electrocardiogram electrodes ready for use. The second step is to move the patient horizontally. Then they are moved towards the opposite side. From the side they will subsequently be turned towards laterally by pulling the bedsheet. The patient should be moved towards the side of the central venous line. After moving the patient sideways, the hand on whichever side they will be rotated onto is placed under the buttock. A new bedsheet is also prepared along the length of the bed. The third step is a side lie. The patient is rotated laterally in a full side-lying position. The patient is maintained in this position for a short time while one person removes the electrodes from the anterior thorax and another person attaches the new electrodes to the back. The fourth step is complete proning. The new bedsheet is used to pull the patient and to move them into the final complete prone position. The body is placed in a horizontal position at 180 degrees. The abdomen is usually not supported. The upper limbs are placed alongside the body. The fifth step is post-proning installation. The patient is moved to the center of the bed. The head is turned laterally and moved every 2 hours. The endotracheal tube must be easily accessible. Care should be taken to close the eyelids tightly and avoid ear kinking. To move the patient from the prone to the supine position, the steps are as follows. The first step is to move the patient horizontally towards the center of the bed. The second step is a side lying on the same side as in step 3 of the proning procedure. The patient is maintained in this position for a short time while one person removes the electrodes from the posterior thorax and another person attaches the new electrodes to the torso. A new bedsheet is also prepared along the length of the bed. The third step is a complete supine positioning. The new bedsheet is used to pull the patient and to move them into the final complete supine position. To summarize the key points of the procedure: trained and experienced staff, 3 to 4 people, good preparation of the procedure, horizontal move, side-lying position, complete proning, and post-proning installation.
Everybody's done it, and there's been no mess up in proning. The first one was done in neuro about 2 months ago. Since then, every unit And if you look at it, we have over 30 patients in the last 5 weeks on vent for H1N1. In 2009, when we did not know about it, we we did oscillation. An average patient had 3 to 5 chest tubes. With proning, no chest tube. Not one person has had pneumothorax. It really, really works. Now, I think it's too early to know, is it going to keep more people alive in the long run from the H1N1? At least they're alive. I know many have gotten better, gone home. I think some of you guys were here in 2009. I mean, we'd had multiple pregnant women died. There's one in MI died with like 6 chest tubes. So oscillation is a good thing, but this proning for ARDS patient really works well. And you can see, like, we had this patient with malaria that was in the trauma unit. I mean, her SAT was in the 70s. 6 hours after proning, her PO2 was 270. So the people that have done this study, they came and walked around with us for a day. They're not absolutely sure why it works. They have theories, so it's still, but it works. The outcome is it works, and our lift team is very good. And nurses have done proning in every unit. CCU has 3 patients being proned every day, and have not been beaten up yet. So it's not that hard, and they're doing a good job, really. So we can go back to our regular schedule event, because I'm running out of time, I guess. So last time we talked about ventilation, and some of you guys probably know as much, if not more, so I have to be careful how much I say. But ventilation, basically we put a person on a vent unless they're not awake enough to protect their airway, neuro patients, overdose and stuff like that, septic shock patients that their work of breathing is too high, or hypercapnic patients like COPD patients. They're so hypercapnic that they're so acidotic that it's just not possible for them to stay awake, and hemodynamically they become unstable. And then the 4th category, the number 1 category, is oxygenation failure, that they're SATs low. So, and most of those patients have ARDS. So, and you use a ventilator to oxygenate by putting PEEP, because whenever somebody has ARDS, their alveoli are flooded with exudates from all the neutrophils coming in and dying and the stuff that's coming out of that. So the alveoli become heavy and thick, and they collapse very easily. The purpose of putting a person on a ventilator is using PEEP. By using PEEP, that means even at the end of expiration, there is so much pressure that the alveoli stay open. It does not get a chance to collapse. But on a regular ventilator, you can use PEEP up to 10, 12, 15. And for some patients, that's not enough to oxygenate them. So that's when we use oscillation or APRV. APRV more often than oscillation, because the same ventilator can do APRV. And if you look at it, I mean, the basic idea of APRV is very simple. Okay, I got to go back to a smaller size. Is this picture right here really summarizes APRV, and what it is. I don't have a cursor, so I might just go up there. If you look at it, APRV, that long stretch. Let me go down one more. Basically, in APRV, you're using a PEEP of 25, 30, 35, or 40, and holding their breath for 2, 3, 4, 5 seconds, and giving short breaks of 0.67 or 0.8 seconds to let some of the air go out so that the CO2 does not go up too high. So, so if you look at this here, right here, if you look at the top line here, is a APRV mode. See how the baseline staying way up at 30 centimeter, and you're giving a 0.8 second break to let the air out. So if you look at the whole respiratory cycle, 90% of the time, the alveoli are held wide open. This is a normal SIMB mode breathing. You can see all this up and down because the person is breathing 30 times a minute. So if you look at it, very short bursts of times when the alveoli are held open. So on an APRV mode, it's flat. And so the alveoli, if they're inflamed, they're friable already. So if you do this again and again and again, the alveoli is going to break. and that means add more damage to a lung that already has ARDS. On APRV, you're just holding less shear, less pull and push. So in animal models, it's been shown that adds less, because whenever ARDS patients put on a ventilator, they have added damage from the ventilator. There's just no choice. The question is, what mode minimizes the added damage? And an APRV in theory is one of those modes that minimizes added damage by having, you can see, a lot less pressure excursion. There's no up and down. Does it make sense? Then I can move on to the next. There's 61 more slides. So it's the same thing talking about it. Oh, I think the screen is kind of small. So APRV in some hospitals, some of you probably moonlight or work in Park Ridge, the same thing, their ventilator call it bivent, but it's the same thing as APRV. And again, the idea is that you are using APRV for oxygenation failure, means a person whose alveoli are so bogged up that normally the gap between the air and the capillary blood is a few micron. When it gets so inflamed, there's a much bigger gap because it's full of stuff. So if you hold it open for much longer period of time, you are, in theory, pushing some of that out of the way, so you have much easier time oxygenating. And also not having all this up and down in the pressure, you're having less alveolar damage caused by the ventilator. And this sort of goes through. I'm going to leave this here if anybody's interested reading more about it. I know there's, so let me go down to, because I have till 7:30, there's 10 more minutes. So again, if you look at it, APRV is basically high level of CPAP with intermittent release, if that is the easier way to kind of remember this. So basically what you're doing, you are, normally CPAP, a person is on 5, 10, or 12 centimeters CPAP. APRV, basically you have 30 or 35 centimeter of CPAP. Basically, CPAP is same as PEEP. That means you're giving very high PEEP. And how much PEEP to give depends on the person's lung compliance. You'll see sometimes the therapist putting in a person on a P high of 25 or sometimes 35. If the lung is stiffer, it's going to take higher pressure to open up the lungs to the same level of ventilation. And so, and it goes through the understanding of ARDS. So the four things that we have to see about in an APRV. First is P high. P high is same as CPAP or PEEP. P high is the pressure when the ventilator is giving the breath, is the pressure it's giving. So normally P high you use about 25 to 30. So P high is the pressure, and how much P high to give, you start at somewhere between 25 to 30, and then you see how much air coming out on the next breath. If 500-600 cc's of air coming out, your pressure is good. If 300 cc's of air coming out, your pressure is not good enough. There's a patient in CCU, P high is at 40, because the lung is so stiff, you got to put in a lot more pressure to get enough volume in that person, so that basically there's two parts to this. One is oxygenation, one is ventilation. So there has to be enough air going in so that the air that comes out getting your CO2 out. So if the stiff lung is going to be higher, so you can start at P high of 25 or 30. And then you see in a few minutes how much their ventilation, how much air coming out, and at the end of the next breath or the breath after, if it's 500, 600, you're good. If it's 200, you gradually increase. So there's no rocket science to it. So that's the P high, or the CPAP. And then there is a P low. P low is always 0. That's just how the machines are set. So the three numbers that we have to learn, APRV is very simple. P high and T high. T high is how long are you going to hold that pressure? Normally start around 3 seconds. 3 seconds, that means P high, suppose you started a person of P high of 30 and a T high of 3 seconds. Means 30 of CPAP or 30 of PEEP, and you're going to hold for 3 seconds. And those 3 seconds, the alveoli just stretched open and improves oxygenation. And then the next number is T low. That means, if I go back a few slides, T low is when you have release of that air. So that is T low. See there, if you can't read it, that is, I'm sorry, I don't have a marker, but you can see there's a little trough on the top line. It's at 0.8 seconds. So T low, like T high, you start with 3 seconds on an average. Means you're holding open for 3 seconds, and you're letting go for 0.8 seconds. And now that 3 and the 0.8, these are just initial set of numbers, and then you're going to have to adjust it. So you let go for 0.8 seconds. The idea is that you're going to not let go of all the air that's in the lung, about half the air or half the pressure, so that you're letting enough air out so that the CO2 does not get to 120. But you don't want to let so much air out, the alveoli collapse altogether again. Then you start the whole process of stretching and opening. The idea is that alveoli stay open all the time. You just partially deflate and reinflate. That way, you're getting your ventilation down, but the change in the pressure in the alveoli is so little that there is very little shear in the alveolar wall, so very little fracture, added damage, and so forth. The other advantage of APRV is, see, there is a little wiggle on the flat top line. That means whenever this P high of 30 holding open for 3 seconds, the person can breathe on top of that. The amount of air may be minimal, but what that does, let the person use their diaphragm. And this has been studied even by doing biopsy of the diaphragmatic muscle, like on CMV mode, which is used frequently. If you leave a person in CMV mode where the machine does all the breathing, even as quickly as or as early as 24 hours, the diaphragmatic muscle starts to lose its muscle mass. So using the diaphragm is very important for a person to wean and extubate and get better. So APRV fulfills that criteria, that even though that you are holding it open, it does not stop the person from doing some spontaneous breathing. So the diaphragm continues to work. And because this holding for 3 or 4 seconds so unnatural, the brain sort of wants to breathe. That little breathing, that's why sometimes you'll see that there's that wiggle in the top line, but it actually is helpful for the diaphragm to continue to work, so the diaphragm does not lose its strength, elasticity, or recoil. So the numbers are just those 3 numbers: P high, T low. And then you start with something. You know, you putting a person on APRV means you are putting a person on APRV because their oxygenation is very low. So to start with, everybody's O2 at 100%. You look at their P high. Suppose you give P high of 30 centimeter, 3 seconds of T high, 0.7 or 0.8 seconds of T low. Then you look at how much air is coming out. How much air coming out, if the air is coming out, say 500 cc's or 600 cc's per breath, 6 liters a minute, you're good. You wait for a blood gas. The only other thing that needs to be readjusted after you first started is the T low. T low is a very important number because, see, if that T low is too long, like how long you let the air out, if it's too long, if too much air comes out, then it kills the whole purpose of APRV. And there is, unfortunately, there's too many slides here, so I got to. And here it goes through what happens, spontaneous breathing versus paralyzed diaphragm and so forth. So it explains all of that. This screen does not fit the screen of the computer. So if anybody's interested, it'll be here. I mean, it's kind of, because you guys really watching the ventilator all the time. A therapist is covering 5 units or wherever else. So, and the T low, okay, here we go through this P high, how to decide what the P high is. T high, we talked about T high and how to set a T high. And then the T low, you can see somehow these 2 screens don't match. So the T low is how long you're letting go. Look at these 2, the white one, see, all the air is completely coming out. That defeats the purpose. So your T low should be just enough, not too much, not too little, so that on that far side, see the brown line that's going down is the air coming in, and the brown line that's going down, air's coming out. The moment it turns straight from right here, you see that's when the valve closing off. So you can see the difference between the two. Here it's letting all the air out. That means the T low is too long. That's just about a correct T low, where the short straight line is half the size of the long straight line. Doesn't make any sense. So you're letting about half the air out. So just enough, and that's how your graph should look like. And then you wait, you get a blood gas. If their PCO2 is 70 and pH is 735, it's fine, because most of these people have oxygenation problems, so you don't want to make their PCO2 normal. You want to make the idea is that as long as the person's pH is at least 725, regardless of whatever the pH is, that PCO2 is, that pH is not going to hurt the person. In theory, there's some animal studies from a long time ago. If your pH is less than 725, then if you're hypotensive, your drugs for blood pressure may not work. So as long as the pH is 725 or higher, the person is hemodynamically going to be stable. At least there's not going to be any hemodynamic problem because of the pH, regardless of the PCO2. You tolerate a PCO2 50, 60, 90, whatever. And so you have a graph like that, you get a gas, and then you go from there. So that's probably the most important thing to setting the P low. And it's really a very easy thing. Unfortunately, there's no machine to fiddle with, so that makes it kind of harder to talk about this. And then it gives you like what is the ideal optimal. That's an optimal, the middle one. This, all the air is going out. There, very little air is going out because it's being cut off too soon. You see the termination points there, and that's basically it. And that's how your graph should look like. And then it goes through a lot more stuff, and if anybody's interested, maybe it's better for me to try to answer questions, and maybe somebody can rehash this. That way we know it went through. And if somebody wants to rehash it, can you come up here and talk? Huh? And then we can quickly talk about the oscillation, because of the flu, now we have 2 patients on oscillator, and there's going to be more people. There will be few people that will need oscillation, because some of them will need ECMO, but there's only so many people can go to ECMO.
Is there an ECMO one right now?
There's one on ECMO right now.
What's auto-PEEP?
Okay. Auto-PEEP is where we're giving a breath before the air from the previous breath has come out. So that means you put in 500 cc's of air, and 300 come out, we give a breath. And another 500. That means that now there's 800 cc's of air. And then 200 has come out, and we give another breath. So then it stacks up to liters and liters, and there's so much air inside the chest that there is high intrathoracic pressure. And then it's so high that your cardiac feeling is down to nothing. So that's basically the result of the auto-PEEP. And auto-PEEP that's what it is. You're just stacking up breath so much that the intrathoracic pressure, like a staircase, keeps them going up. Yeah, like your patient down in MSICU. I have asthma patient. It's auto-PEEPing, yeah. Okay.
Dr. Shome, when you start a patient on APRV, how long does it take to reach, optimum for those settings? I mean, is it instant?
It's about 2 hours. So book says that get a gas in 2 hours. If you get a gas too soon, because it really opens up so many alveoli that if you get a gas 10 minutes later, if PCO2 may be 7, you get a gas 2 hours later, PCO2 could be 20 or 30, because so many alveoli open up that a lot more CO2 goes out. So you wait 2 hours to get a gas.
Thank you. So it takes about 2 hours to reach optimum.
And the question also comes, what should be the initial P high, or the pressure? Therapists, whenever they chart one. There's a couple of things they chart on the ventilator sheet. One of them is called plateau pressure. Plateau pressure is you give a breath, and at the end of inspiration, you hold the breath. There's a breath hold button. And then there's no more air going in and out. And you see what's the intrathoracic pressure at that point. And that pressure tells you how stiff the lung is. And when you go into to APRV, you see what the plateau pressure is, +5 is your initial pressure for P high. This is probably boring information. Okay, I have 2 more minutes. So oscillation. This is not my making, these are smart people from Stanford made this thing for the oscillators we bought. A same concept as APRV. Basically is a big brother of APRV. In APRV, you have this T high and T low. You're holding for 3 or 4 seconds, letting go for 7 or 8 seconds. In oscillation, there is no T high, T low. It's always T high. That means you set it on an oscillator, you set a mean intrathoracic pressure. Like an APRV, like a P high of 30, oscillator will be mean pressure of 30. And it's always 30, you know. And then you have oscillation, that jackhammer-like thing that goes on, you know, 6 or 7 hertz. 6 hertz means 360. 1 hertz is 60. So 6 hertz, 6 times 60. You know, in children, you go sometimes even 8 or 9 or 10 hertz. And so there is no, like normally the concept of ventilation on a ventilator, so much air going in, so much air coming out. You know, and that's like tidal volume and rate and all that. When you go into APRV, that's kind of halfway gone because you're holding for a long period of time and letting go for a period of time for the CO2. And so in oscillation, you're not letting go at all. You're constantly holding the alveoli open, then, and that way the alveoli really have a chance to completely open up as much as possible. In theory, that should improve your oxygenation because the alveoli is not collapsing and reopening, and some of the crud gets pushed out of the way. But then the question is, how do you ventilate? So that's the oscillation part of the oscillator. So in the oscillator, once the pressure is given, that pressure is there, you know, 30, 35, 40 centimeter pressure. And then this oscillation, there's that little rubber diaphragm you see going like that, is putting in a little oscillation of 2, 3, 4, 5 cc's of air at a time. So there is no more breaths, maybe 3, 4, 500 times a minute, that constant flow of air going in, and it's pushing the old air back out. So that way, you never have to let the alveoli deflate. You just, this is kind of like a convection wave, you know. So it's slowly pushing the old air back out with this oscillation. And that's how the CO2 goes down. That's how the new air with oxygen going in. And that's oscillation. And there's 70 slides to talk about it, but that is oscillation. Oscillation is a step up from APRV. You just constantly open, and this oscillation waves putting in new air slowly. So it's a slow process instead of 500 going in, 500 coming out kind of process. And then it goes through, you know, who should be on oscillator. It's always an ARDS patient, really, because you have an oxygenation issue. And it goes through step by step how to set it up, you know, and it goes through, like this is a standard stroke volume theory, like on a ventilator, but in oscillation, you don't have any of that. And it explains further if anybody's interested, and it's copied over here. Now, so in APRV patients, because you're only breathing them holding for 3, 4, 5 seconds, letting go for 0.7 or 0.8 seconds, their CO2 is often high. And you just, like we talked about, you tolerate high CO2 because the people don't die from high CO2, people die from oxygenation failure. CO2 is not harmful as long as it's not causing severe acidosis. And oscillation is even a step up from that because even less ventilation is happening. So their CO2 goes up even more. So you use a bicarb drip. Sometimes you do it all the time. You know, a bicarb drip, the goal is to maintain a pH around 7.25 or higher. That way there is no adverse hemodynamic consequence from the high PCO2. And then if you live with that for a while, within 24 hours, kidney starts to generate more bicarb. And you'll see patients on oscillator or APRV after 2-3 days, the PCO2 is 70, the bicarb is 40, and their pH is 7.32, and you don't need the bicarb drip anymore. So this is called permissive hypercapnia, and is done for every kind of ARDS patient, be it on oscillation, be it on APRV, because our goal is to keep the person alive until the underlying process gets better. And to keep the person alive, we have to do provide enough oxygen and make sure the person's not too acidotic from the high PCO2. I talk funny, but it's here. You're welcome to copy it and read it.
I just want to make one comment to everybody, especially if there's new people in the room. If your patient is on a ventilator and they have a swan, you're supposed to get all your readings at end expiration. I mean, that is what it's supposed to be. But if they're on APRV or the oscillation, you cannot get that 0.8 second end expiration. You won't get it at all with the oscillator. So it doesn't matter when you do your readings when they're on those types of ventilators.
And the prime example is NeuroBed 8, our name. Did you hear about it? Like Wage is constantly reading 28. And it depends on all the people involved. The only way to do it really, you have to quickly disconnect patient from the vent and do it. That's how I was trained in Chicago, but people are very nervous about that doing here. They don't do it. If you depend on it. In fact, then go back, there's been 6 trials that had looked at Swan-Gaines number-based therapy that comes from high-risk medical patient, high-risk surgical, high-risk vascular, thoracic, heart bypass. In every group, Swan-Gaines-based therapy has increased mortality. So this is what the person that trained me, Dr. Gunder, he said, God gave some people good sense. For the rest of you idiots that he pointed finger at me, he created Swan-Gaines catheter.
But we're still getting some. We're still getting
Yeah.
some